Welcome to AETCM, the Emergency Medicine Channel. Today I'll be presenting a case of a patient, a 72-year-old female patient, who presented to ER with complaints of oral ulcers, generalized tiredness, and complaints of fever. Patient on initial 10-second assessment, patient was conscious and oriented, talking in full sentences. Saturation was 96% in room air, and airway was patent. There was no drooling or any secretions or gurgling sounds were present. Breathing wise, saturation 96% on room air, respiratory rate of 24 per minute. Air entry is bilaterally equal. There are bilateral crepitations, scattered crepitations are present. Circulation wise, the heart rate, pulse rate was 80 per minute, BP of 130, 80 millimeters of mercury. And disability wise, GCS was 15 out of 15. Pupils equal and reacting to light. There are moving all four limbs. GRBS was 242 mg per deciliter. Exposure wise, temperature was 100.1 degree Fahrenheit. At this point of time, we had placed a 18 gauge IV cannula and injection PCM 1 gram IV stat was given. Adjuncts, we had taken a ECG, and ECG was showing a heart rate of around 106 with sinus tachycardia. ABG taken showed a pH of 7.46, PCOT of 32, bicarb of 21.4, lactate of 1.8, showed a respiratory alkalotic picture. And we proceed with the sample history.
What are the conditions you get respiratory alkalosis?
Respiratory alkalosis usually we get in the initial phase of a lower respiratory tract infection as respiratory alkalosis, or it can be in hyperventilation states, mostly
Acute
anxiety,
acute respiratory infection,
or even in anxiety
hyperventilation
attack
state.
also. Anxiety attack, it can be there, and also in pulmonary embolism initial stage.
Pulmonary
Most common
embolism.
finding in ABG will be respiratory alkalosis.
Then what other conditions respiratory alkalosis like features patient can have, but it will never develop an alkalosis. Go to alkalotic side in pH. That means you get tachypnea, not because of respiratory reasons. Decay. Any acidosis. Correction part of acidosis is tachypnea. Okay, they also can have alkalotic features, but it will never go to the compensation, will never become an overcompensation. That also you should know. Okay.
Then further sample history. Patient is a 72-year-old female patient, known case of type 2 diabetes mellitus, subsystemic hypertension, obstructive airway disease, rheumatoid arthritis. Now came with complaints of oral.
What lung diseases are common in rheumatoid arthritis?
Rheumatoid arthritis usually can have ILD, interstitial lung disease can be present.
Then. What is the type of lung disease? You told it is obstructive airway disease. That's why I'm asking. It will be mostly restrictive lung disease. Okay. They can have pleuritis, pleural thickening. That will produce restriction. Then they can have rib problem, like inflammation of ribs or a rib end. Then they can have restrictive disease. They can have scleroderma associated condition that also produce restrictive lung disease. Rarely they can have pleural effusion, respiratory infection, all these things. But obstructive airway disease as such is not very common in rheumatoid arthritis, but patient can have associated obstructive airway disease. So you have to be very careful when seeing a patient with respiratory disorder in rheumatoid arthritis.
And patient actually had complaints.
Who has diagnosed this obstructive airway disease?
That was initially diagnosed from outside hospital, and further patient was on meter
Have
dose
they done
inhaler.
any PFT during
PFT showed obstructive pattern.
Okay.
And patient had actually complaints of painful oral ulcerations and generalized tiredness since 1 month, and it had aggravated.
Painful oral ulcerations can be seen in which all problems in rheumatoid arthritis. What are the reasons for painful oral ulceration in a patient with suspected or diagnosed case of RA?
Rheumatoid arthritis patients on methotrexate, if there's first sign of toxicity, can be oral ulceration. Due to
so that is the most important cause. Other conditions, other problems.
Vasculitis.
Okay,
Can present as
vasculitis can produce inflammation and produce oral
oral
ulcers.
ulcers.
Behçet's disease.
Behçet's disease.
That can be associated. Secondary Behçet's can be there. Then oral infections, fungal, bacterial,
candidiasis.
viral, everything is possible. Okay, then. So you have two important problems. One is methotrexate induced bone marrow suppression and oral ulceration. And other things is other inflammation or other infection producing oral ulcers. From oral ulcer itself, you can make a diagnosis. That view of the oral ulcer, how do you diagnose?
It will be due to methotrexate induced. It will be usually pale or whitish. There will be no signs of inflammation.
Okay, so that is
Because
very
already,
important. Normally, there will be
neutropenia.
pale ulceration and there is no surrounding inflammation.
Because of
Whereas all
neutropenia.
other things, you will have severe pain ulcerations,
Redness,
surrounding redness, everything will be there. So that is a major difference.
And this patient also was admitted in our local hospital with these complaints 1 week back, and there was diagnosed to have severe thrombocytopenia and was transfused 4 pints
What is
of
Feltis syndrome? Feltis syndrome. Huh? Feltis. This is in rheumatoid arthritis. Feltis syndrome is a syndrome where you have neutropenia with rheumatoid arthritis. Sometimes you can get splenomegaly. Some patients can have even thrombocytopenia. But classically is neutropenia. Okay, thrombocytopenia is not well known. Okay, but they can have autoimmune thrombocytopenia, immune-mediated thrombocytopenia is possible in RA. Okay, so everything is immune-mediated. So rheumatoid arthritis, SLE, Behçet syndrome, everything is immune. So here also you can get immune-mediated thrombocytopenia.
And after the patient was transfused 4 pints of platelets.
What is the HB level in this patient?
HB here, patient's HB was 6.
Is it a immune-mediated hemolysis or a blood loss anemia?
This looking more like methotrexate-induced bone marrow suppression.
Methotrexate-induced bone marrow suppression is an acute problem. Neutropenia is more common than anemia. Anemia will develop. To develop anemia, you need to have at least 1 or 2 months of bone marrow suppression. All of a sudden, anemia will not form. So neutropenia is the first one to develop, then thrombocytopenia. Then it takes some time to produce anemia. So anemia cannot be due to bone marrow suppression by methotrexate. What are the other reasons?
Then the iron deficiency anemia also.
Iron deficiency anemia is okay, one reason. Then you don't think that these cases will be very simple. Okay, if you miss this, everyone will miss.
Then
if you are able to make a possibility of diagnosis, then others will investigate. What are the
like GA bleed has to be ruled
out. Okay, GA bleed because he is taking a lot of NSAIDs. There is a possibility. GA bleed induced iron deficiency anemia is common.
In this patient, stool OB was also positive.
Okay, so that is one reason. That is the diagnosis here. What are the other reasons? What is the other reason for bone marrow suppression in this rheumatoid arthritis? Anemia of chronic illness is another possible reason. Then, which viral infection produces bone marrow suppression? Parvovirus. So, parvovirus is another common problem in methotrexate, steroid, or any oncology patient. They come with parvovirus, HIV. So, that also you should think. Okay, there is no major treatment, but you should think about that. Okay, what is Evans syndrome? What is that? You all recently finished NEET exam, so you should be able to tell. Evans syndrome. It's immune-mediated hemolysis with immune-mediated thrombocytopenia. So all these things are immune-mediated. So when you are seeing a case, there are a lot of diseases can be associated with the rheumatoid arthritis. So you should be able to make differential diagnosis like this. Okay, may or may not. But if you miss, possibly nobody will then look into it. You transfuse, you give platelet transfusion, everything will be all right. Okay.
And then they had patient was initially on tab methotrexate 5 mg once weekly since 2.5 years.
Okay.
And recently dose was hiked in another hospital
Okay.
to 2.5 mg on alternate days.
2 point?
2.5 mg alternate days since last 1 month.
Oh, okay.
And
That is very high
initially
dose.
once weekly, and then after they made some hospital, they went that time, they made it change the dose to 2.5 mg on alternate days. Since 1 month she's been on that. Then after that, she also had history of high grade fever with chills since 3 days, and also mild cough with expectoration was associated with the fever. And
Was he taking folic acid?
folic acid irregular folic acid supplementation was
That may be the reason, not because of the hike in methotrexate dose,
Trexate.
because methotrexate dose will be, average dose will be 7.5 to 25 milligram per week. Even if it is 2.5 alternate days, it will be how much? It will be maximum 7.5 or 10. That's an usual dosage. But if she don't take folic acid, then it can create issue. What is the type of action this drug produces on folic acid?
basically this for the synthesis of the amino acid, the thymidine, actually the pathway is first folic acid is converted to dihydrofolate, and dihydrofolate is converted to tetrahydrofolate with the help of enzyme dihydrofolate reductase.
Okay.
So this enzyme is basically inhibited by methotrexate, and this prevents the further activation of that thymidylate synthase enzyme by the tetrahydrofolate, because that compound is not being formed. Thus, the methotrexate is inhibiting the folic acid formation.
Okay.
And further, that amino acid formation won't be there, and then cell death like that will occur.
Okay, so
So in
folic
cancer cells and all, this mechanism is used. So initially, they'll target most of the cancer cells, and the cell death will occur due to inadequate amino acid formations. And after that, we'll be supplementing with folic acid or folinic acid, and after that will replenish the folic acid required for the amino acid synthesis in the normal cells. So in that way, we can prevent the normal cell death and only target the cancer cells for death.
Okay.
So
So it's a folic acid antagonist. What type of bone marrow suppression can be produced by methotrexate? What is a peculiar type of bone marrow suppression? It's an acute problem. So acute problem, mostly you have only neutropenia. Neutropenia is the most common thing. This thrombocytopenia may or may not be there. Anemia will never happen because it's a short-term problem. Okay. So you have to find out reasons for other things. Okay. Neutropenia is classically due to this one.
Patient was also on other medications like metformin for type 2 diabetes mellitus and amlodipine 5 mg for hypertension, and on intermittent meter dose inhaler used for OAD. Patient otherwise we had examined on examination wise, patient had pallor. There was no icterus, cyanosis, clubbing, lymphadenopathy or pedal edema, and also and the chest examination revealed air entry was bilaterally equal, but there was some amount of crepitation, scattered crepitations more over the right side. There are crepitations were more in the mid scapular region and the mammary and mid scapular region. And for the CVS examination, S1 S2 was normal, there was no murmurs, and per abdomen wise it was soft, non-tender. Bowel sounds were present. CNS wise also GCS was 15 out of 15. There are no focal neurological deficits.
What neurological problem can be produced by folic acid deficiency? Peripheral neuropathy. Peripheral neuropathy is a classical problem produced by folic acid. B12?
B12, subacute combined degeneration,
Subacute combined degeneration, peripheral neuropathy, optic neuropathy. So many problems can be produced by B12, but this simply peripheral neuropathy. But pregnant ladies, it is a problem. Why we are giving folic acid to our pregnant ladies?
neural tube defects.
Neural tube defects can be formed. It is not very much proven, but even now they receive. No, I don't.
Yes, folic acid supplementation. This patient, we had started initially, we had sent the all routine blood investigations were sent including CBC, LFT, RFT, and electrolytes, and the HB was found to be 6.03, platelet was 50,000, and total counts were 252. Neutrophil was 12.7%, absolute neutrophil count of 30.
So how do you manage
And
this case?
this patient we have to actually keep in isolation and give proper
What is reverse isolation?
uh,
Reverse isolation.
reverse
Is this
isolation.
patient require isolation or reverse isolation?
Reverse
So
isolation.
he requires only reverse isolation. If there is an infection in this patient, it's okay. But this patient requires actually reverse isolation. What is that reverse isolation?
As part of neutropenic care, only one will
It's
assign.
almost same, but at present patient is not having any problem. From the healthcare provider or others, patient should not get any infection.
So we have
Whereas
to use
isolation means patient is infected, he should not infect others. Okay, so almost similar. Okay,
and we have to wear gloves while
Okay.
touching the patient, and we have to discard it. If we are touching other patients, that gloves have to be discarded.
Okay.
Where PPE kit has to be worn, and we have to ideally, if we are having a staff for the sufficient staff, we'll have to assign a single staff
Okay.
for taking care of that patient. And all the ports of the IV line and all can be cleaned with sterilium or alcohol swab before giving any infusions or injections. And we have to wear the patient has to wear mask, surgical mask or N95 mask has to be.
Surgical or N90?
N95 mask has to be worn ideally. And the
Surgical mask, will it
no,
prevent any
only
infection?
dust.
Only dust. Okay.
And staff also has to wear N95
Okay.
mask.
If
And
you want to prevent infection, N95 has to. Otherwise, to avoid smell or dust, this is enough. Surgical mask.
And for this patient, also we had sent RFT wise, creatinine was normal 0.6, LFT was also normal. Sodium was 133 and potassium was 2.8. And serum methotrexate levels were also sent, and chest X-ray was also taken. Chest X-ray showed a non-homogeneous
What is the
opacity.
importance of serum methotrexate level here?
Serum methotrexate level helps us to guide the treatment. So initially, in this patient, we had started on
What is your opinion about that?
glucose.
What is your opinion? Serum methotrexate level has got any value in this patient or not?
We can once we start on injection leucovorin.
Now tell me this one. First
taper
finish
the
that.
dose.
What is the importance of this investigation in this patient? Serum methotrexate levels.
Usually the target for a endpoint for stopping.
Is this problem created by the methotrexate dose or something else? You give us only 10 milligram per week. It is not very high dose. We know that it is a very small dose. What is the problem here? It is here folic acid was not given. That is a problem. So whether the methotrexate level is low, below normal, adequate or above normal, it is not going to create a problem here because it is only very small dose. Maximum allowed dose in rheumatoid arthritis itself is 25 milligram per week. Here only maximum it comes around 7.5 to 10. Okay. There is no value for that. Even then it's okay.
So regular dosing also, that history also we cannot.
Suppose patient is like taking multiple drugs, we don't know what drug he is taking, then that may be helpful. Okay. But here it is, problem is folic acid deficiency. So how do you manage that?
We have to start on folic acid, 5 mg.
Folic acid or?
And leucovorin, 15
Folinic
mg.
acid. Folinic acid.
Folinic
It's
acid.
not folic acid. Folic acid can be continued, but our treatment should be
leucovorin was started, folinic acid.
What is the dose?
15 mg IV we can start every 6th hourly we have to give. This is a rescue regimen. And also orally if we are giving, we can give 15 mg we can give.
And it's available 25 milligram tablet. I think so.
Leucovorin calcium.
I think it is 25 milligram. It is calcium, leucovorin calcium.
Leucovorin calcium.
Okay.
And also we have to then send the ideally according to guidelines, we have to send the methotrexate level, and we have to continue the dosing until it is less than 0.1 micromole per liter.
Okay.
So in this patient it has come around 0.3 micromole per liter, and the dose was hiked to 25 milligram 6th hourly. And we are also started on filgrastim, GCS of simulator, and that 5 microgram per kg dosing.
So that is CSF, colony
stimulator.
Tell me indications for colony stimulating factors.
Ideally used for patients with chemotherapy induced neutropenia.
Only one indication, that is chemotherapy induced neutrophil. But we use in Like many other conditions also, what is out of the counter. We can use it, but it may not be really indicated. But the drug-induced neutropenia is a classical condition where we should use it. Okay.
And filgrastim 5 microgram per kg, which is approximately 300 microgram in this patient, we have started OD. And we had also started on antibiotics. We had started on injection meropenem 1 gram.
Yeah, how do you correct the anemia? How do you correct the thrombocytopenia?
Anemia workup we had sent in which
That show the
iron levels
stool.
are normal. Serum iron levels are normal 88. TIBC was on lower side. It was around
Iron is normal.
iron levels are
Ferritin?
normal. Ferritin levels are raised 1533.
Okay, what is the reason?
CRP was also raised.
Why ferritin is elevated?
Here as part of, and also infection is there.
So
Underlying
do you
infection
think
is there.
it's an iron deficiency anemia?
No, not iron deficiency. Iron deficiency and TIBC will be on
So
higher side with
do you
this
treat
low iron.
this anemia?
Stool OB was positive.
It's okay, stool OB was positive, but that is not contributing to your anemia. It is something else. Stool OB positive that produces anemia means it has to be iron deficiency. So here we can give iron anemia of chronic illness. Erythropoietin can be
give when iron supplementation.
Okay.
Yes.
What is thrombopoietin? Tell me some drugs.
Thrombopoietin using
L-thrombopag.
immune thrombocytopenia.
Can we use the L-thrombopag in this patient?
Usually,
don't tell everything. Every question you should not tell yes. You should argue. Can we give or not?
Already bone marrow suppression is there, then there is no.
There is something called as logic. You are telling logically already bone marrow suppression there, platelet are low, so we can give. But indication?
usually immune thrombocytopenia.
There is no indication. It is not used in all these conditions. It is only indicated in hepatitis C induced thrombocytopenia. Other conditions it is not recommended. But immune thrombocytopenia, like you told, there also you can give it. But it is immune thrombocytopenia, is it a bone marrow suppression or something else? It's a peripheral destruction. So their indications are not very clearly understood and it's very costly also. But logically, if you tell, it may be useful, I don't know. But clinically, it is not, theoretically, it is not indicated anywhere.
And then patient also had in chest X-ray, there was right-sided non-homogeneous opacities was present.
So pneumonia is there. How do you manage that?
We started actually patient on injection meropenem 1 gram.
What is suspect first? Then tell me what is.
Suspect streptococcus pneumonia and antifungal coverage.
What is suspect? You tell your suspicion, then treat the patient. Meropenem is okay. I am not questioning meropenem. What is your suspicion?
Community acquired pneumonia.
Community-acquired pneumonia. What is your suspicion?
Positive gram-negative coverage.
But ILD is there, then we can suspect like pseudomonas.
So that has to come. Pseudomonas coverage has to be there. Whether this is pseudomonas or community-acquired pneumonia, pseudomonas coverage has to be there. In a neutropenic patient, if you are getting a pneumonia, first thing should come to your mind is it can be pseudomonas. It may be, like you told, it may be streptococcal community-acquired. But pseudomonas has to be covered. Will this drug cover pseudomonas? Yes. So it covers. So you are correct by starting meropenem, that's okay. But pseudomonas should come to your mind. This may be pseudomonas. What are the anti-pseudomonal drugs?
Anti-pseudomonal, piperacillin, tazobactam,
ceftazidime, piperacillin, tazobactam, and carbapenem. Okay.
And
what is dual drug therapy in pseudomonas? Dual drug therapy. Single drug therapies are not very good in pseudomonas, but it may be okay. But this patient may require dual drug therapy. What is dual drug therapy? What are gram-negative? Both should be gram-negative one. What is the other drug? One is like he told meropenem or piperacillin tazobactam. Other drug. One is fluoroquine. One can be fluoroquine or aminoglycoside. especially tobramycin. It can be given as IV or nebulization. Okay, so that has to be given. Otherwise, like we should think and give. Like you have started morapanam, that is high-end antibiotic. Okay,
And antifungal coverage also will.
antifungal coverage also should be given for this
Injection
patient.
fluconazole was started 400 mg OD was given. And
There is a loading dose. Second day onwards,
make it 200 mg.
200 is
200 mg OD.
okay.
A patient basically methotrexate, high dose methotrexate is actually more than or equal to 500 mg per meter square.
Okay.
Whereas intermediate dosing is 50 to 500 milligram per meter square, and low dose is the less than or equal to 50 milligram per meter square. It mainly actually it is used in conditions like fast treatment of acute leukemia or lymphoma, osteosarcoma,
Okay.
or any
All these conditions are that
leptomeningeal.
acute lymphoma, leukemia, or intentional drug intake. These methotrexate levels are very useful. But conditions like rheumatoid arthritis, where we use very low dose of methotrexate, this may not be very useful. That's all.
Then leptomeningeal metastasis and all, they can be used. Whereas we can also use intermediate doses like 50 to 500 in malignant gestational trophoblastic disease, and low doses are used in breast cancers.
Okay.
And basically this is excreted via kidney unchanged. It is excreted via kidney, so it usually gets precipitated in the renal tubules and can damage the tubules.
Okay.
So if there is any acidic urine or any volume depletion and all, it can further exacerbate the renal damage, and this renal damage itself will cause further decreased excretion of this methotrexate, and this can further increase the levels in the plasma and cause toxicity.
Okay.
And the other toxicities which it can cause is it can damage the liver, then kidney, we have said, and then lungs, then
Liver,
skin.
what will happen? Lung, what will happen? Liver and lung, you told. What will happen? Acutely, hepatitis can be produced. Chronically, what will happen? All these things are entrance questions. That's why I am asking. You recently finished NEET, so you should be able to tell. Fibrosis, liver fibrosis, lung fibrosis, all these things are side effect of methotrexate. But normally we don't see in rheumatoid arthritis, but in other conditions like where we use very high dose, we can see all these things.
Then other skin toxicities can be skin mucosal involvement. Then, as we said, bone marrow suppression. Bone marrow involvement can be a neurologic peripheral neuropathy.
Whenever bone marrow suppression is there are two differential diagnoses. One is drug induced, other one is parvovirus. So that you should keep in mind. Okay, both are possible.
And then we have to actually, for pre-treatment, before starting the patient on methotrexate, we'll have to send the renal function, see the baseline creatinine, and if there is any third space fluid collections, then we'll have to, if there's any pleural effusion or ascites, we'll have to drain prior to the treatment because it can increase the concentration and prolong the action of methotrexate.
Okay.
And then other drug-drug interactions can occur with NSAIDs or any anti-epileptics like phenytoin, levetiracetam, or antibiotics like ciprofloxacin, or any penicillin antibiotics and all. It can increase the action. So that also has to be avoided. Then the urine output and urinary alkalinization and hydration. That is another step of management in which we will have to give around 2.5 to 3.5 liters per meter square per day of fluids will be required, and the urine output has to be also maintained more than 1 ml per kg per hour. And after that, we'll also have to see for urinary alkalinization using sodium bicarbonate, because if there is acidic urine, as we have discussed, just it will cause
What is the name
precipitate
of
in
this
the
treatment?
alkaline
Post alkaline diuresis. Alkaline diuresis and give Lasix, it will become post.
And we can add either in the fluid itself we can add sodium bicarbonate, or we can start orally sodium bicarbonate, and this will also help in the rapid clearance of that methotrexate. Or if it is acidic, it will then precipitate in the renal tubule and cause tubular injury. And then we'll have to start on leucovorin rescue therapy. So as we have discussed, either we can start on 10 mg per meter square, or we can start on 15 mg per meter square. And orally also we can start with the tablet available is leucovorin calcium 25 mg per meter square. Every 6 hours we will start, and we should ideally start within 24 hours of the start of the methotrexate infusion. and this should be continued until the plasma methotrexate levels are less than 0.05 to 0.1 micromoles per liter. And then monitoring, we have to do creatinine monitoring, electrolytes monitoring, and the plasma methotrexate level monitoring we have to do. And if there is any, as we said, acute kidney failure and all, we'll have to manage with same hydration, urinary alkalinization has to be done. Then another therapy is the glucarpidase therapy. That we can start if there is a higher levels of methotrexate. So if there is based on the infusion duration of that methotrexate, if it is usually less than or equal to 24 hours infusion duration, then we can give based on the creatinine levels. If it is significantly elevated related to the baseline, then we can like check the plasma methotrexate concentration. At 36 hours more than 30 micromoles per liter, or at 42 hours more than 10 micromoles per liter, or at 48 hours more than 5 micromoles per liter, we can start on glucarpidase. And 36 to 42 hours infusion duration, we can start at 48 hour methotrexate concentration greater than 5 micromoles, you can start on glucarpidase.
It's not available in India.
India is usually not used. And based on methotrexate elimination also, if there is a normal methotrexate elimination, then if the serum methotrexate levels are approximately 10 micromoles at 24 hours or 1 micromoles at 48 hours, or less than 0.2 micromoles at 72 hours, we can start a dose of 15 mg orally or IV or IM every 6 hours. For 60 hours we can use. And after the start of that methotrexate infusion, if there is a delayed late methotrexate elimination, then you have to see the levels again. Serum methotrexate level above 0.2 micromoles at 72 hours and more than 0.05 micromoles at 96 hours, then we can continue the leucovorin 15 mg every 6 hours until the levels are less than 0.05 micromoles. And if there is delayed early methotrexate elimination or evidence of any acute kidney injury, then we'll have to see higher level targets will be there. So methotrexate levels will be more than or equal to 50 at 24 hours, more than 30 at 36 hours, or more than 5 at 48 hours. And or if there is any rise in creatinine levels, like a 0.5 to 1 mg per deciliter from baseline, we'll have to give a higher dose of glucovorin 150 mg IV every 3 hours, and until it is the levels are less than 1 micromoles. And then after that we can start on 115 mg our dose, we can start 15 mg every 3 hours until the levels are less than 0.05. So and if there is also then acute kidney injury, we can use glucarpidase, but not available.
Any role for dialysis?
Dialysis only it's a temporizing measure.
Okay.
We'll have to combine it with other treatments, leucovorin and
Okay. Anything else you want to tell? Nothing. Okay. Thank you. You want to tell something?
No.
Thank you.
Thanks.